Imagine a biological ticking clock inside a developing embryo. Every hour, a completely different part of the human upper limb is meticulously constructed, from the shoulder right down to the fingertips.
Yeah, it's a highly precise assembly line.
Right, but what happens when that clock stutters? Like, what happens when a genetic misfire or a vascular accident just stops the assembly line cold?
You get some incredibly complex anatomical anomalies.
Exactly. So, welcome to this rapid fire revision deep dive, tailored specifically for you, the resident preparing for board exams like the FRCS in plastic surgery.
We're both plastic surgeons, and our mission today is to completely deconstruct congenital upper limb deficiencies.
Yeah, specifically focusing entirely on failures of formation. And look, we are skipping the pleasantries today. We want you to hit the follow button on your player right now.
And if you learned something valuable during this discussion, rate the show.
And to take your revision to the ultimate level, get a premium subscription to access our dedicated journal club and clinical cases deep dives.
It's the best way to prepare.
Definitely. So today, we are moving purely through a question and explanation format. We're tracing the embryonic limb from the simplest morphological interruptions down to the complete derangement of the initial blueprint.
Right.
Let's start with the most straightforward failure of that biological clock, which is transverse arrest. Give us the clinical picture.
Sure. So when we talk about transverse arrest, you should visualize a limb that simply stops developing at a very specific horizontal plane.
Like a congenital amputation.
Exactly. That's exactly what it is.
Mhm.
And technically, this failure can happen at any level, from the humerus all the way down to the phalanges.
But clinically, for the exams, what's the classic presentation?
The one you'll see in practice, and definitely on your exams, is an arrest at the junction of the proximal and middle thirds of the forearm.
Right, so below that line, the limb just simply does not exist.
Right. It's just absent.
And from a management perspective, we are largely looking at non-surgical options here, correct? You are aiming to fit the child with a prosthesis starting around, 6 months of age?
Yeah. Right as they begin to develop bilateral hand usage and sitting balance. That is the textbook timeline. You introduce the prosthesis at 6 months.
But there is a catch, right?
A huge catch. There is a crucial clinical reality you need to understand for your exams regarding unilateral deformities.
Okay.
Children with a transverse arrest on only one side, they almost universally discard these prostheses as they get older.
Wait, really? Just discard them entirely?
Yeah.
Because the sensate residual stump is ultimately more useful to them than a piece of plastic?
That's exactly the mechanism. A child relies heavily on tactile feedback to interact with their environment.
Ah, right, the sensory input.
Yeah, a bulky, insensate mechanical tool at the end of their arm deprives them of that input. So they quickly figure out they can accomplish tasks way faster by using their contralateral normal hand for fine motor skills.
And then just using their sensate residual stump to, pin or stabilize objects?
Exactly. However, if there are metacarpal remnants present distal to the arrest, well, the paradigm shifts entirely.
Then you'd actually operate.
Right. We might look at surgical interventions like distraction lengthening of those remnants or performing a free microvascular toe or phalangeal transfer.
Just to provide a basic sensate pinch mechanism.
Yes.
Okay, let's shift from a clean horizontal cutoff to the more complex syndromic failures. Let's look at the pre-axial border radial longitudinal deficiency.
The big one.
Yeah, this is the most common longitudinal failure, right? It affects, 1 in 55,000 live births, but the name itself is almost a trap.
It's a massive trap for candidates.
Because calling it a radial deficiency implies we are just talking about a missing bone.
Right, and you must conceptualize this as a spectrum of abnormalities affecting the entire radial side of the upper limb. It is a regional failure.
So it's not just the radius.
No. Yes, the radius bone is hypoplastic or absent, but so is the radial carpus, typically the scaphoid and trapezium.
And the thumb.
Exactly. The thumb is often missing or severely underdeveloped. And it extends to the soft tissues, too.
Like the nerves and vessels?
Yeah, the radial-sided tendons, ligaments, muscles, nerves, blood vessels, they are all anomalous or absent.
Wow.
And because the structural support of the radius is gone, the intact ulnar muscles just pull unopposed.
Which results in that severe radial deviation of the hand.
Right. Historically, this was called a radial club hand.
Okay. And the high-yield exam goldmine here isn't just the anatomy, is it? It's the genetics.
Oh, absolutely.
Because up to 40% of unilateral cases and a staggering 77% of bilateral cases are syndromal.
Yes, which dictates that every single one of these patients requires assessment by a pediatrician and a geneticist.
Yeah.
You can't skip that.
We need to break down the 4 heavy hitter syndromes. Let's start with VACTERL. I always joke that medical professionals will force absolutely any set of letters into an acronym, but this one actually dictates our trauma level assessment of the newborn.
Yeah, the Vactral Association is a perfect example of why you cannot just look at the hand.
Right.
The acronym stands for vertebral anomalies, anal atresia, cardiac defects, tracheal anomalies,
Yes.
specifically tracheoesophageal fistulas.
Nasty.
Yeah. Esophageal atresia, renal and radial abnormalities, and other limb abnormalities.
So if you see a radial club hand, you have to immediately wonder if this child also has a life-threatening airway or cardiac defect.
Immediately.
And we have Holt-Oram syndrome, which carries an autosomal dominant inheritance pattern and pairs the upper limb malformations with cardiac septal defect.
Right, the hard-hand syndrome.
Exactly. But let's look at the 3rd and 4th syndromes, because I feel like this is where exam candidates really trip up TAR syndrome and Fanconi's anemia. Both are autosomal recessive.
Yes.
So if you were standing in a clinic looking at a child's hands, how do you clinically differentiate TAR syndrome from the other 3?
The classic defining discriminator is the thumb.
The thumb.
Yeah. In TAR syndrome, which stands for thrombocytopenia absent radius, the thumb is usually present.
Oh, okay.
I mean, it might be slightly abnormal, but it is there. In Vactral, Holt-Oram, and Fanconi's, the thumb is typically hypoplastic or just completely absent alongside the radius.
That is the crucial FRCS distinction right there. But we also need to emphasize the absolute stakes with Fanconi's anemia. Radial deficiency affects 40% of patients with Fanconi's.
Yes, it does.
Why does missing this specific diagnosis represent a catastrophic failure by the surgical team?
Because Fanconi's anemia is a rare cause of bone marrow failure. These patients will develop aplastic anemia, usually around age 6, and it is fatal without a bone marrow transplant.
So if you focus entirely on reconstructing the wrist and fail to diagnose the underlying Fanconi's.
The child will die from hematological failure. It's that serious.
Okay, so we've run the genetics, we've ruled out the life-threatening syndromes, and now we are looking at the physical deformity itself. We have this classic bowed presentation of the forearm. Let's talk about the mechanics of the fibroassemblage. From my understanding, if the radius is completely or partially absent, it leaves behind this fibrous band.
Yes, the alage.
Should we think of the anlage essentially as a rigid bowstring that forces the growing ulnar bone to bend and just tethers the hand into radial deviation?
That bowstring metaphor is the absolute perfect way to visualize it. In German, the word Alage literally translates to foundation or plan.
Okay.
It is the embryonic tissue that was supposed to become the radius, but it just never ossified.
So it just stays fibrous.
Right, it becomes a thick, unyielding fibrous band. As the ulna continues to grow, it is tethered by this non-growing alage.
So the only way the ulna can accommodate its own increasing length is to bow outward.
Exactly, while simultaneously dragging the carpus and hand down into severe radial deviation.
We classify this failure using the Bain and Klug classification, right? It's a 4-part system based purely on the radius.
Yes, type I to IV.
Type 1 is a short distal radius. Type 2 is a hypoplastic radius. Type 3 is partial absence. And type 4 is total absence of the radius. So looking at the surgical timeline, how do we physically dismantle this deformity?
Well, the timeline begins long before the scalpel.
With physio.
Exactly. Initially, parents are instructed to perform physiotherapy on the infant's elbow and wrist at least twice a day.
And the goal there is purely passive stretching.
Yeah, purely passive stretching to prevent progressive, irreversible soft tissue contractures.
Okay.
We also frequently use external fixators to slowly distract and stretch those tight radial soft tissues over several weeks prior to the main operation.
And when is the definitive surgery?
The definitive surgery itself is typically performed around 12 months of age.
Okay, so when we go in at 12 months, we have 2 primary reconstructive philosophies, right? Centralization versus radialization.
Yes.
Break down the mechanical differences for us.
Let's look at centralization first. The goal here is to physically reposition the carpus directly over the distal end of the ulna. You stabilize this new position by driving a pin through the 3rd metacarpal, through the carpus, and straight down into the medullary canal of the ulna.
But the soft tissues are so tight.
Right. So to achieve this, you have to perform an extensive soft tissue release, usually excising that fibrous analogue we talked about.
And then rebalance the muscles.
Furthermore, you have to rebalance the muscle forces. You take the radial wrist extensors and transpose them over to the ulnar side, specifically attaching them to the extensor carpi ulnaris, or ECU.
Just to counteract that anatomical tendency for the hand to pull back into radial deviation?
Exactly.
And how does radialization differ from that?
In radialization, instead of centering the whole carpus over the ulna, you place the scaphoid specifically over the ulna,
Oh, I see.
and you secure it by driving the pin through the second metacarpal rather than the third.
And the muscles.
Then, for the muscle rebalancing, you transfer the flexor carpi radialis and the flexor carpi ulnaris over to the ulnar carpus, or the fifth metacarpal.
Wait, I'm visualizing the mechanics of centralization, and it sounds a bit like balancing a golf ball on a flat tee.
Yeah.
Like the carpus doesn't naturally fit the distal ulna.
No, it doesn't.
Doesn't this lead to massive mechanical complications?
You've hit on the exact flaw of the procedure. Because the carpal bones don't conform to the ulnar head, both centralization and radialization suffer from notoriously high recurrence rates.
The soft tissues just stretch out.
Yeah, they stretch out and the hand slides right back down into radial deviation. But even more critically, driving pins and placing immense compressive forces on the distal ulnar physis frequently causes a growth arrest.
Oh, wow. So you end up with a profoundly short forearm.
Right.
Which brings us to the Wilkie procedure. This is where reconstructive microsurgery offers a brilliant biological solution to what is essentially a mechanical problem.
Precisely. To avoid destroying the ulnar growth plate, Wilkie described a microvascular transfer of the second metatarsophalangeal joint, the MTPJ, from the toe.
Taking a joint from the foot.
Yeah. By transferring a living vascularized joint to the wrist, you provide a biological strut that supports the carpus and allows for a functional range of motion, completely bypassing the ulnar physis so the forearm can continue to grow.
That is amazing. But it sounds technically demanding.
It's highly demanding, requiring complex microsurgery in an infant. But it elegantly solves the golf ball on a tee problem.
Let's move to the hand itself, because this is a classic high-yield exam station. The child has a severe hypoplastic thumb that cannot function. We need to perform pellicization of the index finger.
The big one.
We are essentially sacrificing the index finger to build a new thumb. Walk us step by step through the anatomy of this procedure, because the spatial rewiring here is incredibly complex.
The overarching goal of pellicization is to reproduce thumb function by shortening, rotating, and re-angling the index finger. There are 8 major steps you must be able to recite seamlessly.
Okay, let's hear them.
Step 1. We make a very specific radial palmar incision. This creates skin flaps at the base of the index finger that will later be wrapped around to construct a wide, supple first web space.
Got it.
Step 2. We must mobilize the ulnar digital nerve. The index and middle finger share a common digital nerve.
Right.
We have to perform an interfascicular dissection, splitting that common nerve high up into the palm so the index finger can be moved independently without tethering the middle finger.
Okay, that makes sense.
Step 3. We ligate and divide the radial digital artery to the middle finger. This frees up the neurovascular bundle so the entire index digit can be mobilized on its own blood supply.
Beautiful.
Step 4, we carefully elevate the interosseous muscles off the shaft of the index metacarpal.
And step 5 is where the major bone work happens, right? We remove the entire shaft of the index metacarpal, keeping only the metacarpal head.
Yes.
Because this head is going to serve as the new trapezium for our constructed thumb. But a vital detail for the exam, we have to resect the epiphysis of that metacarpal head.
Right. Because if you leave the growth plate intact, the new trapezium will continue to grow longitudinally inside the base of the thumb.
Ah.
You eventually end up with an absurdly long, disproportionate digit. Destroying the epiphysis stops that longitudinal growth, fixing the foundation at the correct size.
Now I want to push back on the mechanics of steps 6 and 7. The index finger naturally points straight forward. A thumb needs to be abducted and pronated to achieve opposition. You rotate the metacarpal head 160 degrees, correct?
Yes, that's right.
But soft tissue tension dictates that it naturally relaxes back to 120 degrees of pronation. And regarding the tendons in step 7, if we just shorten the bone by removing the metacarpal shaft, our flexor and extensor tendons are now way too long.
Yes, they are.
I've heard debates about whether to physically cut and shorten these tendons. Can you clarify the current consensus on this?
Your geometry is spot on. We over-rotate the head to 160 degrees because the surrounding soft tissues and skin flaps will inevitably pull it back. It settles perfectly at 120 degrees of pronation, which places the pulp of the new thumb directly facing the remaining fingers for opposition.
Perfect.
We then pin it with K-wires in 40 degrees of palmar abduction, with the MCP joint hyperextended to prevent a buckling deformity.
And the tendons.
As for the tendons in step 7, traditionally surgeons would measure the exact millimeter length of the metacarpal shaft they removed and excise that exact length from both the flexor and extensor tendons.
But not anymore.
No, many surgeons today do not shorten the tendons at all.
Why?
The physiological reasoning is that skeletal muscle has a remarkable ability to adapt its resting length. Over several months, the muscle bellies will naturally retract and take up the slack on their own.
Wow, that's fascinating. Which brings us to step 8, the rebalancing of the intrinsic muscles. This is where we turn index finger abductors into thumb muscles. This rewiring is a puzzle you just have to memorize.
It is pure biomechanical genius.
It really is.
The first dorsal interosseous, which normally abducts the index finger, is sutured to the radial lateral band. Because of the new 120-degree rotated position, its line of pull now acts as the abductor pollicis brevis, or APB.
Okay.
The first palmar interosseous is sutured to the ulnar lateral band to become the adductor pollicis. The extensor indicis proprius, the EIP, is transferred to act as the extensor pollicis longus, the EPL, allowing the child to lift the thumb out of the palm.
Got it.
And finally, the extensor digitorum communis to the index finger is rerouted to act as the abductor pollicis longus, or APL.
It is a complete masterclass in redirecting force vectors. Yet despite this perfection, candidates must remember that many of these children will still require a secondary opponentsplasty tendon transplant between 5 and 8 years of age to optimize pinch strength.
Yeah, that's an important caveat.
Let's transition from the preaxial border to the postaxial border. The embryological failure shifts to the opposite side of the limb bud. If radial deficiency gave us a stiff elbow and a highly unstable wrist, how does the mirror image ulnar deficiency alter the biomechanics?
Ulnar deficiency is essentially the inverse in its presentation, though statistically it is only about 1/10 as common as radial deficiency.
Okay.
It presents a spectrum from simple hypoplasia of the ulnar digits down to complete absence of the ulna. The biomechanical flip is fascinating because the radius is usually robust and intact. The wrist joint is actually quite stable.
The elbow.
Exactly. Because the ulna is missing its proximal articulation at the trochlea, the elbow joint is highly unstable.
How do the syndromic associations compare? Because we just spent a lot of time on cardiac and marrow defects for the radial side.
Ulnar deficiency is much less likely to occur as part of a systemic syndrome. When it does have associations, they are predominantly musculoskeletal-like scoliosis or fibular deficiency rather than cardiovascular or hematological.
That's a huge distinction.
Right. You will also always see involvement of the hand and carpus. Missing ulnar digits, severe syndactyly, or thumb abnormalities are guaranteed.
And there is a strange morphological paradox here, right?
Yeah, in radial deficiency, total absence of the bone is the most common presentation. But in ulnar deficiency, partial absence of the bone is the most common.
We use the Bain classification for ulnar deficiency as well, which again features 4 types. Type 1 is hypoplasia of the ulna, where both the proximal and distal epiphyses are structurally present but small. Type 2 is partial aplasia, where either the distal or middle third of the ulna failed to form.
Right.
Type 3 is complete total aplasia of the ulna. And type 4 introduces a unique complication, a radiohumeral synostosis, where the radius is fused directly to the humerus. From a surgical standpoint, what is the primary target for release here?
Just like in the radius, we are hunting for the fibrous annulus.
Of course.
In types 2 and 4, the missing segment of the ulna is replaced by this dense restrictive tether. It must be surgically excised. If you leave it alone, it acts as a bowstring on the ulnar side, causing progressive ulnar deviation of the hand and forcing the growing radius to bow severely.
And for type 4, the radiohumeral synostosis.
Well, the elbow is fused solid. You can't magically create an elbow joint. So instead, we perform a rotation osteotomy of the humerus.
You just break the arm and turn it?
We literally cut the upper arm bone, rotate the entire fused forearm into a functional position so the hand can reach the child's mouth in midline and fix it right there. Hand function is then optimized by releasing any syndactyly and deepening the first web space.
Okay, we've covered the radial and ulnar borders. Now let's drive our discussion right down the midline to tackle central ray deficiencies. For the boards, you have to draw an absolute impenetrable line between typical and atypical cleft hands. They look similar to a layperson, but embryologically they are completely different animals.
That distinction is paramount for your exams. Historically, everything was lumped under cleft hand, but today we separate them.
Let's look at the typical cleft hand first.
So this is a true central deficiency. It presents as a deep, V-shaped cleft right down the center of the hand, often missing the middle finger and its metacarpal.
And the genetics.
It is frequently bilateral, it frequently involves the feet, and its inheritance is autosomal dominant, meaning you will almost always find a family history.
Okay.
It is often part of a larger genetic syndrome like split hand, split foot malformation, or EEC syndrome, which stands for ectrodactyly, ectodermal dysplasia, and facial clefts.
And contrast that with the atypical presentation.
The atypical presentation is no longer called a cleft hand. It is properly termed symbrachydactyly.
Right.
It is characterized by short vestigial digits. Instead of a clean V shape, you see small, unformed nubbins of tissue in the center of the hand, often with tiny vestigial nails attached.
And it's unilateral mostly.
Unlike the typical cleft, symbrachydactyly is almost always unilateral. It almost never involves the feet, and it occurs sporadically with zero family history. It is frequently associated with Poland syndrome, the absence of the pectoralis major muscle.
Interesting.
In fact, its place within Swanson's classification of congenital hand anomalies is heavily debated. Many experts argue it is not a true longitudinal central ray deficiency at all, but rather a failure of the apical ectodermal ridge.
Which classifications do we use to map these two entities?
For the typical cleft hand, you must know the Manska and Helicas classification. What is brilliant about this system is that it completely ignores the actual cleft and focuses purely on the first web space.
Oh, really?
Yeah, it ranges from type I, where the thumb web space is totally normal, down to type V, where the web space is completely absent and the thumb elements are suppressed. The logic is simple thumb function dictates hand function.
That makes a lot of sense. And for symbrachydactyly,
We use the Blouth and Gakeler classification, categorized into 4 morphological types.
right.
The short finger type, the oligodactylic type, which looks like classic central aplasia,
Right.
the monodactylic type, where only the thumb remains, and the paramelic type, which is the complete absence of all fingers in the thumb.
There is a famous, slightly brutal phrase you will hear in pediatric hand clinics regarding the typical cleft hand. A functional triumph, but a social disaster.
Yep.
You hear that a lot. These children actually have phenomenal pinch and grasp mechanics despite having a deep split down the middle of their palm. How does that functional triumph dictate our surgical timing?
Because their baseline function is so good, we do not rush into complex reconstructions just to make the hand look normal.
Okay.
Early surgery, meaning under 1 year age, is strictly indicated only to prevent progressive structural deformity. For example, if there is a syndactyly tethering 2 unequal digits, or if there are transverse sideways lying bones in the cleft that will force the hand wider apart as the child grows, we remove those early.
And the actual aesthetic closure of the cleft.
That is postponed until the child is between 1 and 2 years old. This is when we reconstruct the first web space and close the cleft.
What are the main techniques?
The Snow Littler technique is a classic. It involves taking a complex palmar-based flap of skin from inside the cleft and transposing it over to deepen the first web space.
And the alternative?
The Mira and Komada method is a slightly simpler alternative involving redraping palmar and dorsal flaps.
But there's a highly specific, high-yield spatial technique regarding the metacarpals during that closure. I want to visualize this.
To close the gap, the second metacarpal must be physically moved over to the third metacarpal, but you don't just shove it over.
Right.
The key technique is performing an osteotomy and transposing the second metacarpal, specifically at the level of its neck, securing it to the base of the third with K-wires.
Why the neck?
Because doing so preserves the origin of the adductor pollicis muscle on the third metacarpal, protecting thumb adduction.
Brilliant.
Furthermore, you have to reconstruct the deep transverse metacarpal ligament to hold the palm together.
How do you do that?
We do this by harvesting the adjacent A1 pulleys from the flexor sheaths. You literally slice the pulleys open and unfold them towards one another like tiny structural drawbridges meeting in the middle,
Oh.
and suture them together to create a new ligament spanning the gap.
Okay, we have covered transverse, longitudinal, and central arrests. Let's finish with the most profound disruption of the limb bud. What happens when the intermediate segments fail to form entirely, but the distal segments survive?
You are describing an intersegmental deficiency, historically and somewhat tragically termed phocomelia. The word derives from Greek, translating roughly to seal limb.
Right.
The defining embryological characteristic is an intercalated deficiency. The humerus and forearm are missing or severely stunted, but the hand itself is always present, attached directly to the trunk or a shortened arm segment.
We absolutely cannot discuss phocomelia without examining its historical link to thalidomide. In the late 1950s and early 1960s, this drug was heavily prescribed to pregnant women for hyperemesis gravidarum severe morning sickness.
This it was.
It crossed the placental barrier and completely devastated the developing limb buds of thousands of embryos.
The tragedy of thalidomide reshaped modern pharmacology entirely. Its mechanism was anti-angiogenic. It literally starved the rapidly growing embryonic limb bud of new blood vessels during the critical weeks of formation.
But a fascinating factual detail you should know is that thalidomide was not entirely banished.
No, it wasn't. Today, because of its potent anti-angiogenic and immunomodulatory properties, it is actively used to treat complications of leprosy and certain cancers like multiple myeloma.
How do we classify and manage the phocomelia we still see today?
We rely on the France and O'Reilly classification, which is cleanly divided into 3 types. Type is complete phocomelia, where the hand is attached directly to the trunk.
Okay.
Type 2 is proximal, where a small forearm and hand are attached to the trunk. And type 3 is distal, where the hand is attached directly to the humerus with no elbow joint.
And manage?
As for management, surgical reconstruction is extremely rare. If surgery is indicated, it is usually minor procedures just to stabilize a floppy limb segment. The primary management is purely prosthetic, specifically aimed at extending the patient's reach so their functioning hand can actually reach their mouth and face for independent feeding and hygiene.
That covers the entire spectrum of failures of formation. Before we sign off, I want to leave you with a final provocative thought to mull over for your exams. Consider how the chronological timeline of embryological development perfectly, almost ruthlessly, maps onto these rigid surgical classifications.
He really does.
Think about how a single vascular accident during gestation or one tiny genetic mutation at week 4 versus week 6 dictates an entirely different reconstructive philosophy years later.
Yeah.
It forces us to choose between highly complex interventions like harvesting and plumbing a microvascular toe joint to save a wrist, all the way down to something as conceptually simple as snipping a fibrous bowstring. The surgery we perform today is entirely dictated by a blueprint that was drawn and altered before the patient was even born.
When you connect the surgery back to the biology, mastering these classifications isn't just about memorizing dry textbook lists. It is about reverse engineering the developmental timeline of the human limb.
That wraps up our rapid-fire review. Again, take 1 second to leave a rating on your player, hit follow, and grab that premium subscription for our clinical cases and Journal Club deep dives. We want to keep this revision going, so please leave a comment or a question down below regarding any of the surgical classifications or anatomical rewiring we covered today. See you next time.